Hello, everyone. So, I'm going to talk about a few things here. I know that some of you had a difficult time trying to access audio or having the ability to listen to my videos. So, I'm going to do it again here so you guys can um, hear me as I'm talking here. So, I will be doing this session on this chat on here. Obviously, I'm kind of reading a little bit here so you guys can see it on the transcript if you need to. So I will be doing this session today so others can use it for note taking as well. For the purposes of the session, I'm going to do a quick overview of some disease state topics here. So here you can see a table that is broken down in different disease states. The first one I wanted to mention are some common nervous system information like the central nervous system and the peripheral nervous system. You can see here, specifically central nervous system, like you could see like depression and psychosis, and then someone having some other kinds of disease states there. Um, Common one you might also see is someone having Alzheimer's and Parkinson's. Do not get confused between the two. Um, is typically one that you might see as patient being on carbidopa or levodopa, those medications, um, as it deals with dopamine. Alzheimer's, you're going to see more like donepezil, rivastigmine, memantine, those kinds of medications here. So just know that those differences. Also notice that anxiety is one medication that almost every customer you might see taking for anxiety. Um, and also note that it is a controlled substance, so um, be aware of that, especially if you get a case question on, like, for a doctor's license expired, and then you suddenly see a prescription on a controlled substance. What would you do? You would have to go ahead and call the office to verify the license um, of who wrote that prescription and whether it is valid, and check for the validity of that prescription before dispensing it to the patient. Um, so there's some ethical concerns here that you should be able to follow in leadership as well. So um, as a pharmacist, it's important to evaluate all of that. Um, on NAPLEX, they might not ask much law, but you might get a case question like that. So as a pharmacist, just make sure you review it before you dispense it to a patient. Another medication you might see on a test is something like fluoxetine, or you might see antidepressants like escitalopram, SSRIs, SNRIs. Um, what does the S stand for? Well, you're going to see one of the most common um, important, I would say, particles in like the nervous system where serotonin syndrome is a possibility that might occur, especially if there's too much serotonin in the system. So, if there's too much serotonin, patient can experience serotonin syndrome, and that could be very bad in terms of side effects. One of the common ones, like seizures, patient could go into coma, respiratory depression. It could lead to get more and more worse after that. So um, look out for any drug interactions that lead to serotonin syndrome as well, especially with SSRIs and SNRIs and any other medication that interacts with these med types as well. Um, so it's important to know that. Um, I wanted to tell you uh, about that this entire review is not a comprehensive review of every medication used, but at least you have an idea for what types of medications used for each disease states. So this is just an opening discussion of the topics in this review. Um, so also you can see here anxiety and depression and what they're indicated for. Um, One other thing I wanted to mention is that there are beta blockers listed on the slide as well. Um, it's not specifically first line, but sometimes you might see it being used um, to help with certain symptoms of depression as well, and other central nervous system related side effects like migraines, like propranolol being used as for symptomatic management of migraines. So, just be aware of that. Um, so I also want to mention with migraines, like the sumatriptan, rizatriptan, that can be kind of that's used for people having those migraines they can't um, prevent. But when patients have migraines, what do you want to do? We want to first start with non-pharmacologic therapy, and that includes maybe um, not staying in very bright areas, um, avoiding certain types of foods that trigger headache, um, and those kinds of things. And also, um, when it comes to pharmacologic treatment, probably the first step is really to try the OTC first, like ibuprofen or naproxen or any of the NSAIDs, maybe with Tylenol. Sometimes you might see over the counter like Excedrin being used. That's another one that might help with it. So before they go into using prescription type drugs, they would use that first. Um, and then for Parkinson's, I wanted to explain a little bit about carbidopa and levodopa here, or Sinemet, which is combo drug, and also very expensive too. Um, the carbidopa is essentially used to hold, I guess you could say it's kind of, I guess you can refer to it like cargo, or, keeping it in the system so that the levodopa works better. Um, because without carbidopa, levodopa is going to break down, and then you can't get that much dopamine out of it released in the system. So um, that's very important to have both together there. And as you can see in the name dopa, dopamine, you can kind of make out that analogy there too. Um, what else I want to talk about here? So classes like MAOB and COMT inhibitors are typically used for Parkinson's as well. Um, so that's pretty interesting there. Uh, so know the differences between like typical and atypical antipsychotics. That's um, important because, in terms of side effects, one is more severe than the other. Um, Give me 1 second. basically, if you look at the typical antipsychotics, they are typically going to lead to more positive symptoms. So positive are usually like things like it might lead to hallucinations, illusions, things of that nature. Whereas the atypical will lead to both positive and negative symptoms. So that one's going to be a little bit worse. Uh, so understand that. Um, let me see. Okay, and then for seizures, you need to know like some of the narrow therapeutic ranges for those seizure type medications. Also understanding some typical side effects like one of them like red man syndrome or like really hot red flashes, rashes on the skin, and all of that. So, like lamotrigine, phenytoin, carbamazepine, less, not really likely, but valproic acid, Depakote, all of those kinds of things. Sometimes you might see benzodiazepines being used for seizures as well, specifically like diazepam or the gel, the diazepam gel. You might see some patients beyond that. Um, Now, when you're in a pharmacy, when you're practicing, um, you may need to adjust the measurement of that, um, the diazepam gel. I don't know if you've seen them before. Um, it's goes by the brand name Diastat. So sometimes you would need to make those adjustments before dispensing to a patient. So kind of understand, Diastat being used for seizures. Uh, Also seizures, understanding the differences between the types of seizures, like tonic, clonic seizures. Then you got those really blindside seizures, or um, and I don't recall the other one, but there's different types of seizures. You should understand where the medication works as well. So understand that. In terms of seizures, I wanted to mention some of the other things about it. Um, you might see, the benzodiazepines typically are controlled substances as well. So kind of be careful with that. Um, and that's pretty much it that I know for now. But if you have any questions, just feel free to let me know. Let's now dive into a respiratory section. So that one's going to be more so dealing with um, asthma, COPD, allergic rhinitis. Um, we already kind of discussed about allergic rhinitis, Claritin, Zyrtec, cough and cold medicines. But when it comes to someone having high blood pressure, you want to give them um, a you don't want to give them something like antihistamines that's going to spike their blood pressure high, and give them something that's going to be leading to lower blood pressures, like quercetin, for example. So, it's to manage the cough and without harming the BP. Um, so kind of understand that it kind of relate to the blood pressure as well. Uh, Also knowing the difference between first and second generation antihistamines. So like diphenhydramine or Benadryl, and then the second generation antihistamines. You can see here that Benadryl, being like the first generation antihistamine, can cause more drowsiness and lead to anticholinergic effects. So also know the anticholinergic effects like dry mouth could occur and what those anticholinergic side effects are. Um, and also understanding that first generation crosses the blood-brain barrier and affect the central nervous system. So that's an important distinguishment between the first and second generation antihistamines. Cystic fibrosis is another important topic to know as well. This one involves a gene defect that might lead to increased mucus production. So it may cause to infections and shortness of breath, um, clogging the airways, and also, affecting other parts as well. So to alleviate that, typically something like tobramycin is used to kill the infections, but you would use something like ivacaftor, or um, uh, Dornase alpha for those things. Pulmonary arterial hypertension involves increased pressure leading to a right side heart failure. So that could um, affect um, the blood flow, especially going out of the heart. So um, what we use for that is one of the uh, things on the vessel is called endothelin, and when endothelins are there, they tend to kind of vasoconstrict, close up that artery. So endothelin receptor antagonists are used, prostacyclins and SGC stimulators, so it can allow vasodilation. And for next one here, sleep disorders, Zolpidem, Zepbound, Temazepam. Melatonin is the best OTC sleep aid that you might see on exam. Sleep apnea typically is best treated with CPAP. Zepbound is another near option for um, sleep apnea, as it is also used for weight loss. Um, so what's the difference between asthma and COPD? Well, asthma is going to typically just be a one-time deal. You're going to it's not going to use as many medications or combined medications like the COPD. In COPD, you're probably going to need a little more extra help here in terms of breathing problems, and it's primarily caused by smoking. So often requires combination inhalers like Symbicort, Trelegy, Duonab. I would also recommend reading over the consultations um, on some of these types of inhalers so that if you're given a question on the test, at least you know what the steps are and how to um, assess the use of an inhaler with that patient. So, having that um, discussion with the patient is important. So, especially in practice too. So, for testing purposes, definitely know the counseling points. One other thing is when it comes to inhalers like asthma, you probably should know that um, an important consideration is definitely like the potassium levels. So albuterol, for example, has a interaction with um, like beta blockers. specifically because it is a beta 2 agonist, so it's going to have, um, with it being beta 2 agonist, it's going to cause bronchodilation. But when you take a beta blocker, you're affecting the bronchodilation. It's going to bronchoconstrict. So there it's going to kind of prevent the use of the inhaler and causing the patient to get more shortness of breath, making the inhaler not work properly. So it's very important to counsel them on the medications here and to let the patient understand that the medication might interfere um, when they're taken together. So um, just wanted to let you know. LAMA is like a muscarinic antagonist. It's used more common in COPD patients. Formoterol has a fast onset, and the salmeterol is slow. Another thing to note here is albuterol can cause hypokalemia, sorry. And so it interacts with beta blockers. So I mentioned that already with you. For arrhythmias, know the Vaughan Williams classification, like class 1, 2, 3, 4, and knowing those will kind of help you for the test on the arrhythmias part. One thing I wanted to mention here in the arrhythmias section is that there are some calcium channel blockers you can use here, like diltiazem and verapamil. You don't want to use these for heart failure. You want to avoid them altogether. Do not take them if a patient has heart failure. But if they have arrhythmias, yes, you would take these. Now, you might ask, what about diapir, or what about the calcium channel blockers like amlodipine? Yeah, you can take amlodipine because amlodipine is just going to help mostly with the blood pressure. It doesn't have much effect on the heart, so that would be fine. So, and also note the 36-hour washout when switching between the ACE inhibitor and Entresto. Um, so that's important. Also, for diuretics, know where furosemide and thiazide work. Knowing all the different types of diuretics, where they work and all, is important. Spironolactone, that raises potassium. Furosemide, that lowers potassium. When to take furosemide, important counseling point. Furosemide, you want to definitely tell a patient or talk to a patient, let them know that they should be taking in the morning, not at night, because they would have to use the bathroom a lot. So it would be better for patients to take furosemide in the morning. Um, Again, monitoring potassium here. Also avoiding ACE inhibitors and ARBs together. Yeah, never take those together. ARBs generally have lower um, chance of causing a dry cough compared to ACE inhibitors. ACE inhibitors tend to cause more dry cough, mainly because it's going to prevent break down that bradykinin, and when that builds up, it leads to more dry cough. So you definitely want to know that correlation. It's important to know, which one is going to cause more dry cough. Verapamil, I mean, like the um, like Citabruv or losartan, those kinds of things. Um, Also know the INR goals for warfarin, because like 2 to 3 is normal, but the mechanical valves you would take, it would be 2.5 to 3.5. Avoid grapefruits with statins as well. And know the penicillin allergies, sulf allergies, black box warning for fluoroquinolones, like tendon ruptures, maybe, and I don't know for sure, but I think it leads to some sort of um, like suicidal thoughts and things like that. So kind of like be cautious of that. The mechanism of action of many of these antibiotics too. Um, Note opportunistic infections are typically by CD4 count, right therapy for the tuberculosis. I'm sure you know what right therapy stands for. Rifampin, isoniazid, pyrazinamide, ethambutol, where ethambutol is typically, you could associate that with like ethanol, alcohol, or something that will affect like the eyesight. Um, and isoniazid, probably thinking more like linked to peripheral neuropathy. So, um, with that, patient would need to make sure that they are taking vitamin B6 so that they can make sure those levels are normal there and to avoid the peripheral neuropathy risk. And the RIPE, which is you can associate that with red in fluids or orange discoloration and sweat, tears, saliva, all those kinds of things. So um, it's important to understand that as well. Avoiding nitrates with PDE5 inhibitors, and that steroids can increase blood sugars and know the glucose ranges. As for gout, monitor the uric acid levels, and motion sickness like scopolamine, meclizine, dramamine is typically used. In sickle cell anemia, patient might need to take hydroxyurea and Pepto-Bismol. You could see some side effects like darkening of stools, tongue. Avoid Pepto-Bismol that contains bismuth subsalicylate in children because of Ray's syndrome. Um, and then Imodium is another medication that might, if taken at very large amounts, could act as like an opioid drug. It's kind of like a partial opioid agonist, so just be careful of that. Even though it's over the counter, azo is typically not taken for long periods of time. You don't want to be on that forever, but typically people take it when they have a UTI, pain with UTI. So it would be an option for pain relief. Um, and that should pretty much cover the first half portion of it. I don't see anything here. Let me take a look. What was I gonna say? Hello, can you hear me now? Hello, everyone. Are you able to hear me? Okay. So, um, give me 1 second. Okay, thank you for responding. Um, so I just wanted to point out a few things here. Um, Especially when it comes to like PPIs, like omeprazole and all. Um, I'm just gonna let you know that you have to be kind of careful when taking things like like I mentioned earlier, like clopidogrel, for example, because of the CYP2C19 interaction there. So that's one thing I would recommend you look at. You might see a patient case on it. Um, so definitely, yes, it will be saved also for your review later as well. So just for your reference. Um, and all these notes as well, I'll also have it posted for you guys to look at. Um, so does anyone have any questions on anything that we just talked about since the beginning of this whole lecture? I know it's quite a lot of information, a lot of material, and I know it's very, you know, frustrating having to review all of this. So I just try to make it a little easier for you guys so you guys can kind of hear some case scenarios and see what happens, if patients taking this or that. So I hope it's kind of helping you guys. um, yeah, but if you couldn't hear me, that's because I was doing most of the typing here. So if you want to, if you see all the previous information above, you can review all of that. um, uh, No, I didn't do the voice recording. I wasn't sure if you actually needed a voice recording or if you wanted me to do the chat. I just did the chat here because some of you guys didn't join till later on. So I see quite a bit of you guys already on here. So I'll just start talking then. Um, so do you have any other questions, first of all? Anybody? Anything? It's a lot of information here. So feel free to ask now so we can review it. Uh, you can definitely email me. Um, in fact, I'll probably just have it listed out and after this video, so you all can email me if you have any other questions. Um, just feel free, or you can actually let me know on this recording as well, or after the recording. Any other questions? I just wanted to stop here so you guys can look through, think about anything. Um, again, this is just an overview. This is not an actual lecture because those topics are there's a lot more to it than just these kind of things. So um, yes, HIV is a little bit of a very long topic to go over. So I'm not going to go over these things specifically, but what I want you to know is what I want you to understand is definitely looking over these class of medications like NRTIs, NNRTIs, the PIs specifically. Because PIs are like protease inhibitors. So you're going to see something like ritonavir. So, they are just used as like a booster to kind of help with helping with, the as an antiviral agent. So, like, I just don't want you to get mixed up between HIV and hepatitis C virus medications here. Because some of the medication, like the generic version of the medications, like they are probably going to kind of overlap with each other. So I think one way to remember these is basically looking at the brand names, um, and knowing like some of the common ones like Epclusa, Mavorite, Harvoni, and those kinds of brand names. So um, one other thing I want to mention, like the hepatitis um, C virus, as you could see, it's a direct acting antiviral. So I think your book kind of defines, those kind of various ways in how to identify those direct acting antivirals. So you shouldn't have too much of a problem, but I think understanding the brand names going to help you out with the distinguishing that with the HIV medications. So hopefully that kind of clears it up a little bit. I haven't really looked too much deeply into HIV to really actually go over this topic fully with you right now, because again, I'm just doing overview right now. Um, but I have listed one short um, a while back, and I think you guys should kind of look over that because it kind of breaks down uh, specific mnemonics on how to remember one versus another. I think there were a few side effects I listed for each one. I would also recommend like understanding definitely the understanding the side effects on these medications. Um, the entry fusion inhibitors, and then I think this is a very easy one, but the knowing understanding between the NRTIs and NNRTIs, that might kind of confuse some of you. So definitely look at that. I will go more into this in the future lecture. I just listed out here for your reference. So, is there anything, any topic you have question on? I don't want to overwhelm you with too much information here, but the purpose is really just to give you a touch base on everything here. So just for your information. Um, I think on this infectious disease slide, you might see a lot of different things here. I wanted to mention one other thing. Uh, I don't know if this is the one, but I think the fluoroquinolones, um, obviously, it can cause tendon ruptures and all. So mechanistically, like there is a probability that it might kind of all affect like the um they call it like they might have a little bit of you know I don't like to say suicidal thoughts, but it possibly could lead to it. But I would recommend you look back at that. Um, it's quite a bit here. So, does anyone have any other questions? Sorry, I couldn't, if I didn't explain everything completely. I just want to, it's a long lecture to go over everything. So I just want to make sure that we kind of hit a little bit of each thing before you start, looking over the resources. Just giving you a few minutes to kind of, you know, think, or if you want to look over anything. There's a few more sections I want to talk about so you guys can remember them. If you would like, I can go over them. Okay. Oh, and one other thing I want to mention. Um, there was a question on a post I read earlier today about the immunizations, vaccinations, and all. This is a very interesting um, uh, time to talk about, since we're talking about infectious diseases here. Um, there is not really going to be any like update from like the 2025 and 2026 vaccines. It's pretty much going to be all the same. Um, Obviously, you probably should look at the CDC website for the most updated information when it comes to the vaccinations. Um, there is like if you're going to look at something like RXV, the RSV vaccine, you probably may have seen like the age um, the age group which people should be getting vaccinated with that. That probably might have changed in the last couple years, so you want to double check on that. Um, I don't think pneumonia has really changed. Probably the most recommended one that most people take is the Prevnar 20 vaccine. Um, and like the shingles, taking Shingrix and the flu vaccines every year. There might be a question on the vaccines, so I think you should definitely take a look at that. Um, so, um, but don't just rely solely on the book because anything could have changed. So definitely look at the CDC website uh, to check what age group should be taking what vaccines. Um, Again, I haven't seen anything changed, so it's probably going to be all the same as the one you have in your books. But just double check to make sure. Does anyone have any other questions? So I think we pretty much hit a little bit of each thing here. Um, you can see a lot of these, different disease states, they do use a steroid one way or another. So, it's kind of important, especially if there's some kind of inflammation going on. So, um, for example, even someone who has sepsis disease or is in a hospital, an emergency, they're going to be put on some kind of steroid. So, um, you know, uh, some of you might get confused on the select all the apply question when steroid is on the options there. Um, I would say definitely when you look at the review in the guides, um, just find out exactly what diseases have a steroid with it. So kind of like you saw like COPD, for example, you saw some of the like the steroid um, combinations in there, and then you saw some steroid combinations, especially for things um, like here you saw like the eyes and ears. Um, you probably saw some other types of diseases that uses the steroids, and you saw inflammatory bowel disease. And I'm about to talk about that next. There is only one steroid that you would probably see for someone in this inflammatory bowel disease. Do you know which steroid that is? Anybody know? If you don't remember, that's fine. Um, so I haven't listed out here because we haven't really fully talked about it, but you want to definitely look back and see what the differences are between the Crohn's disease and ulcerative colitis, and the steroid medication that typically they use for those kind of inflammatory bowel disease states. Um, Typically, something like the steroid that's typically used is the budesonide. Now, you might say budesonide being used for like COPD or asthma, but it's actually used in combination. Um, but sometimes you might see it being used as a brand name inhaler, like what is it? I don't know if I have it spelled right, but um, so like you might see Pulmicort being used, but in most cases, the budesonide capsules or the tablets, those are used for the inflammatory bowel disease. So that's a particular steroid to know for that um, disease. So if a question comes up and patient has an inflammatory bowel disease like Crohn's disease or ulcerative colitis, and they need to be on a steroid, this is the steroid medication they would use for it. Um, One thing I wanted to note here is methotrexate. Um, Methotrexate is also used for arthritis. So you might see someone taking methotrexate for arthritis. So, it's important to know that it can be used for that as well. Methotrexate is also going to deplete folic acid. So that's why folic acid is important in this case. It's not important for bacterial infection because you want to kill the bacteria. So it doesn't matter if the bacteria cannot produce any folate in there. So, of course, using the Bactrim DS is useful for that. But for methotrexate, you want to replenish um, the folate by taking folic acid or vitamin B9. So understand that. And mesalamine, sulfasalazine, you can see some of those medications being used for inflammatory bowel diseases here as well. There was another interesting article I saw a little while ago. It was on the vancomycin. Has anybody heard about this medication? It was just a recent publication, and I think it was on Pharmacy Times sometime around November or December this year. Um, Looks like um, it's another type of medication that can help with GERD or with um, acid reflux disease without um, using a like um, works a little bit differently. So just wanted to point that out here. Let's take a look at some of these other ones here um, about like pain medications. I'm sure if some of you have worked in a pharmacy, you probably have seen patients, taking hydrocodone, oxycodone, morphine, methadone, and all of those kind of opioid controlled C2 medications. Um, yes, but what is relevant in terms of the exam is they're probably going to trick you into thinking, you know, that they might put a exam question, they might say Percocet, and then on an option they might have Tylenol on the test. So you have to know also when it comes to pain medicines, the Tylenol has a limit as to how much you can take in a 24-hour period. Does anybody know how much Tylenol you can take in a day maximum? Anybody? It's okay if you have don't really know it, but you know, there has been controversies between taking between 3 grams and 4 grams Tylenol, but typically the max is going to be 4 grams of Tylenol in a day period. I think the generic version you can take at 3 grams as maximum. But yes, so you might have a calculation here, and they might ask you, about how much, uh, based off this medication, how much Tylenol that they are allowed to take in that day, or how much they have taken, So you have to understand how much Tylenol you can take actually in a day, and because Percocet is a combination of oxycodone and acetaminophen, so um, that's going to be duplication therapy. So definitely, just want to make sure you understand that. NSAIDs, um, ibuprofen, Advil, naproxen, um, those are important medications, but some of these medications uh, will affect also like the gastrointestinal part of the body too. It might cause the more bleeding and those kinds of things. So someone taking a blood thinner, you want to be careful with taking NSAIDs as well. Um, and I believe aspirin is one that they would consider as like an NSAID. So aspirin as well, and shouldn't be taking NSAID. They're going to be on aspirin, basically. Um, what I wanted to mention in terms of like the NSAID, it is very much also probably going to hurt the kidneys, like especially like the ibuprofen. So something to watch out for in patients, and doing particular dose adjustments and things um, for that, or just recommending Tylenol. But Tylenol is typically used for reducing fever, but sometimes it helps with a little bit of pain as well. If their kidneys are getting really bad, you probably don't want to give them NSAIDs. You want to give them Tylenol. If there's creatinine clearance level is below like 30 um, milliliters per minute, or it's getting down to like 10 milliliters per minute, you probably want one NSAID in that case. Um, in terms of like opioids, one side effect I highly recommend you guys remember is that it might lead to respiratory depression. What have we talked about previously? Um, we talked about someone who is already taking um, albuterol, right? So let's link this back to albuterol. Patients taking albuterol because they're not able to breathe. They have like asthma or they have COPD. Let's say a patient is smoking, they have COPD, then they're gonna be on some kind of duonap or albuterol hypertropia. Now they want to take this pain medicine. Um, as a pharmacist, would you actually recommend them taking a high dose, let's say 10/325 milligram of hydrocodone, and taking it maybe 6 times a day? And then, another medication like benzodiazepine, it's also a possibility that can lead to respiratory depression as well. So, just kind of pointing out a few scenarios here, because respiratory depression is important here too. Patients, sometimes you might see them on codeine allergy, and that they um, are prescribed something like this. Again, it is a codeine derived type of drug, so you want to definitely be aware of all of this as well. So again, look at the allergies. Sometimes patient has allergy to penicillin. Sometimes they have allergy to, um, some medication allergies is important. So definitely look at that. Now going to oncology, I list out some of these for you just to kind of categorize them a little bit by the medications used to treat those kinds of cancers. Um, um, I did wanted to ask you, does anyone know um, the CD or the rituximab? Does anybody know anything about rituximab? Because rituximab is a medication that can, that they use for like the blood type of diseases, but it's like a CD20 antigen. So like it binds to a CD20 antigen. So that's something I wanted to kind of point out. So um, there might be a question on this. You might see something like this. So definitely want to look at those CD values here, this especially CD20. They might have a choice. They're probably going to try to confuse you. They might ask you which drug or binds to this antigen. So know that. Um, and paclitaxel for like non-small lung cancer, for example. Paclitaxel is can lead to peripheral neuropathy. So definitely, note some of the side effects here. Uh, um, my recommendation when it comes to oncology is draw the chemo man. Have you ever seen a chemo man? Have you seen it? It's probably in your RX Prep book or you World book, where you'll probably see a chemo man diagram. Um, just go over that chemo man and try to draw it out on your own. It's probably going to help you kind of see the medication where the um, toxicities are listed. So I actually have one. I had one video here posted, um, so you can review that chemo man diagram in there too. In fact, I might be able to put it on here for your reference. If I can find it, give me a second. It's a very, very rough diagram, but at least you guys have an idea as to what the, I guess it won't let me post it here. Let me just see if I can post it on this slide here. Maybe you can see it here. Sorry if it's a little bit blurry here, but yeah, so you can see how vincristine and the taxanes are usually like leading to like peripheral neuropathies. You can kind of see bleomycin. Bleomycin is an interesting one because that one uh, kind of it's just right there, the lungs. It's going to kind of affect the lungs there. So, know that. Uh, and Oh, okay. So yeah, it's not very clear, but you'll want to definitely look at the chemo man diagram. and kind of understand all the toxicities. I think that's going to be very relevant for the exam, this topic here. Um, uh, Trying to think. Um, I think understanding like the HER2's positive, HER2 negative is important, especially for the breast cancer portion of it. Um, and um, yeah, and that's pretty much all I can remember, what I can think of to kind of help you out with this section on the exam. And then these last two I wanted to talk about here, the diabetes and the thyroid disorders for endocrinology section here. Specifically, like the first one here, metformin. Um, some people considered it as like an anti-aging type of medication. It's a theory, but it's not really, studied. So, but I just wanted to mention it there. But yeah, so these are all just general classes of like um, diabetes medications like metformin. You got a GLP-1 agonist, SGLT2 inhibitors, DPP4 inhibitors, and different types of insulin. Um, when it comes to like the blood glucose, sugars, and stuff, you want to definitely pay attention, know what the ranges should be, especially fasting and the postprandial blood glucose. Need to know the A1C, whether a patient is above or below 7% A1C. Um, and knowing when to test the A1C. Typically, it's every 3 months. So, should understand that as well. Um, Also, a patient without diabetes, knowing that how much uh, until they get to like the pre-diabetes stage, and then until they reach diabetes, and understanding those ranges as well. So review that as well. Understand what's a rapid acting, long acting insulin, and then ultra long acting insulin as well. Um, like examples, like Lantus, you have Tresiba, Trulicity, you have things like, short acting like Humalog, Humulin, and all of those kinds of insulin as well. And then Apidra. Um, so, yeah, so know all of that. GLP-1 agonists, understanding things like um, Monjaro, for example, and knowing that as well. SGLT2s, SGLT2 inhibitors. You guys should understand also there's one particular drug there, or one class of medications there, that SGLT2 inhibitors that um, you may have seen in the pharmacy being dispensed. I'm sure you have also seen Farxiga and um, Invoke, well, maybe not really Invokana, but um, it might be in some practice. So, um, just understanding these classes of medications, where they're, used. Yeah, we already talked about some of these previously, especially, um, and yeah, I've talked about in the course also. Um, but um, I wanted to also list out one more use for diabetes, although it was not listed here. Also, I consider sulfonylureas too, like the three Gs, the glipizide, glyburide, and glimepiride. I'm sure um, you may have seen that in practice. The glipizide, glimepiride, and glyburide, they all have tendency of causing a little bit of weight gain. So understanding like some side effects here as well. Um, what was I saying? Um, oh, give me 1 second. Also noting that potassium is also affected um, when taking insulin as well. So there's a possibility that hypokalemia might occur. So definitely another risk, especially along whatever um, you just said here, increased risk of hypoglycemia. Yes, definitely hypoglycemia risk there. So I would recommend you also look at the counseling points, especially now that you mentioned hypoglycemia. Patients gonna have an A1C or not A1C, probably gonna have a glucose level probably less than 70. Then you definitely want to make sure that they are going to have something with at least 15 grams of carbs that's going to help replenish their sugar levels back to normal. So understand some counseling notes on um, in here. Um, and yeah, I don't know anything too much more on this. Um, definitely keeping consistent carbohydrates um, per week, having those kind of good exercise and dieting and all that, non-pharmacologic therapy. That's pretty much it there. Um, Levothyroxine, thyroid disorders. Um, I'm sure you guys may have read about them, but levothyroxine is usually going to be used as a synthetic T4, and the T3, which is the liothyronine. I'm sure you guys have seen this, but um, understand those differences there. Um, the T4 is going to be broken down to T3. T3 is the more active form for the thyroid. So take um, a look at that. Um, there are some other drugs I haven't listed here, but there's one drug that combines these two together. But it's I don't really recall the name, but it is there. Um, and it works, you know, as a T4 and T3. So you might want to look back at that too. Um, I think there's some percentages there. They could ask you how much percent of T4 is going to be used compared to T3 from this medication patients on, just in case. Um, take a look at that. And also a counseling point, to definitely take this on an empty stomach. I know I haven't listed like NP thyroids or armor thyroids, but those are some other medications for thyroid diseases as well. And then common skin conditions, steroids, again, retinoids, tretinoids, specifically. There is one drug I haven't really listed here. Does anybody know what drug that is that requires an additional process for like RAMS approval? Do you know what drug that is? I did not list it in this slide here. Or does anyone at all know that drug? Does anyone know what RAMS is at all? REMS? Correct. Accutane, isotretinoin. So that's the one that requires additional approval process. Yes. So that one requires RAMS approval um, authorization. So that one's an additional that's an important medication, and you could see something like on a test, and so know that as well, and I think on their label you have to write it, they have to have a discard after date, or at least going back to shelf or something. But that's actually more on the law side of the exam. In terms of NAPLEX, at least understanding that that's one medication that you should not use it unless you get that RAMS authorization, because of the risk that it presents with. So definitely know that as well. It's a vitamin A derivative or a retinoid. It's definitely can cause severe birth defects, so that's why they require iPledge enrollment. Okay, that's what it was called. So iPledge is needed for that one in case they ask you about that. Um, uh, Sometimes there might be some infections on the skin, so they might use antibiotics, antifungals. There's sometimes sunscreen is used for skin condition. Um, so I think having said that, you'll probably get some kind of maybe you might get a test question on this. I particularly haven't really seen it, so you may not, but it's possible you might get one. Benzoyl peroxide, I'm sure you can probably find that like over the counter as well. That's another typical drug that people use. And that's pretty much it for the skin conditions. I didn't really have too much here. These are some other agents. I think we pretty much covered it all. Does anyone have any questions? I know it was kind of a long lecture. Just feel free to ask. I'll just keep it open for 15 minutes. If you guys have any questions, just feel free to let me know. I really appreciate for you all attending this lecture. I hope all the um, information I presented here um, has been, somewhat helpful here. This was mainly just a comprehensive review of all different disease states and types of medications that you probably see on a test. Majority of them are going to be like on these topics here. I pulled all of these topics based off your UWorld review, um, or off their website, they had like all these topics listed. So I thought maybe, these tables might kind of help you all kind of break down the different types of drugs. I try to distinguish one by another so you can kind of see what differentiates between one and another disease state. Um, I didn't want to overwhelm you with the material, but you know, I know it's a lot, so you guys are free to use these as your guide. Um, and I will also present uh, lectures in the future. Um, and this was actually very quick. Um, I know it's a very short time frame to get you in this lecture, so but I'll make sure to let you know in advance, when I post my future lectures. Um, in the meantime, I do highly recommend everyone to um, go through um, some of the lectures I posted in my channel here, and just look over it. Just it doesn't have to be. You're not memorizing anything here. Do not ever memorize anything on for an exam. You want to actually understand the material, kind of like how I create patient scenarios. Kind of create those patient scenarios for yourself as you're studying. Um, there is um, one video, very interesting video, um, and it's related to renal diseases. Um, I highly recommend you guys to look at that, um, because as the renal disease kind of relates to a lot of cardiovascular disease states, you're going to need to at least understand some of those concepts as well. At the end, when a patient is experiencing, when their potassium levels are very high or their spironolactone is increasing or jacking up their potassium levels, um, what to use, how to move that potassium from outside extracellular surface to the intracellular surface of the cell, when they should be using insulin to kind of deplete that potassium level so it doesn't get too high, or when they should be on albuterol, or even taking calcium gluconate for the moving of that potassium level. So I would recommend taking a look at that. Uh, it's a short actually, so you'll probably see it on the um, in this channel, um, and that's that will pretty much cover the entire renal disease section of the chapter for you guys, so you guys can look at that. Um, and I would also recommend two other things. Um, DOACs, definitely want to look at like all the direct oral anticoagulants like rivaroxaban, apixaban. Now on the shelf you might see Eliquis, that's the brand name being used, um, dabigatran, and um, you know, and betrixaban. So you guys see all of those. Um, you guys need to go over all of those drugs as well and look at what levels they monitor as well. Um, and I think you should also look at the warfarin colors. and the levothyroxine colors as well. There is a video on that, kind of has a breakdown of those colors for you, so you guys can review that. Um, right, another counseling point to remember, metronidazole. Patients on metronidazole, you should never take with alcohol. So avoid alcohol use when on metronidazole. So does anyone have any questions so far? You might see a question on test about sotalol and sotalol AF. I guess a quick way to remember the two is really definitely understanding the sotalol AF is typically um, the AF meaning AFib. So someone who has AFib and uh, they are taking sotalol for that. So just need to understand those difference in that indication, knowing the difference between the typical and atypical antipsychotics, the first generation, second generation of the antihistamines, and also knowing the types of diuretics, thiazide, loop diuretics like furosemide, um, potassium sparing diuretics, and then knowing also trientine, or also the antibiotics sulfamethoxazole, trimethoprim, where trimethoprim also increases the potassium level in case they ask you that on the question on the test. So understand that. Um, Also swelling in the legs when they're taking amlodipine, beta blockers decreasing heart rate, um, beta 1, beta 2 selectivity. So that's all pretty much disease states. I'll be doing more further in-depth reviews on these slides, so you guys can be familiar a little bit more into this. And I'll also post some questions, more questions on this. But as of right now, you guys probably already have a set of 100, 200 questions in these video collections that's already posted that you guys can actually use to review them, and probably over 60 calculation questions for your review as well as any references, formulas, and all of those things that are presented in this channel. It's all on there for your review as well. So just take a moment to go over all of that. I also have biostatistics information on there, so you guys can review some of the formulas there, like relative risk, and also understand the PKPD formulas as well. So you guys should be able to do all those calculations as well. For like the compounding sections, like sterile compounding, non-compounding, the garbing orders listed in there too for you guys to review that as well. And also going over like the ISO values as well, when what ISO values they should be in when they're in buffer zone versus when they're in a clean room, going over all of that as well. Very important. And also look over the excipients as well when you look at the compounding sections in the chapter. Um, I listed those as well for your reference. Um, and yeah, so we'll pretty much cover pretty much everything. You guys will be able to do uh, this exam and get out really confidently and be able to pass it on that first try. So hopefully all of this has been helpful. And again, thank you for attending this review. I hope every thing has been, at least whatever we talked about was kind of, helping you recall some information um, while you were studying for it. So I'm going to leave up a poll here. And if you guys want to take the time and just give me a little bit of feedback, I would really appreciate it. Just wanted to see if you found this video helpful. Um, and or if you can just respond to it, that would be actually really helpful to me, at least so I can come up with a plan as to how I want to help you for your future lectures. Um, so please, um, so just please let me know how I did in this video, and if you can, if you would like, I can uh, post some more information for you guys so you guys can use it as a review. Um, Again, like I said, I've done everything I can to help you here. You have a bunch of practice questions that you can go over with answers in all of them. Probably maybe 200, 100, 200 in there. You got probably over 80 different, or probably 60 or 70 of those calculation questions. Top 200 drugs are all in there, so you guys can review those drugs. Now, the top 200 drugs um, are basically like listed in a way for you guys to think about as you're reviewing for the test. Um, because when you go over the top 200 drugs, you need to know everything. Like you need to know the brand, generic. You need to know why that drug is relevant. Basically, what it's used for. Not just understanding brand and generic, but what it's used for. Uh, things like we talked about here, like what level should be monitoring in the labs. Um, what does it interact with? Is it contraindicate with anything? Like avoiding grapefruit juice with atorvastatin, or avoiding, eating too many green vegetables or vitamin K when you're taking warfarin. Those kinds of things. Take a look at that. And like Gentolin, I mean, but like take a look at that and the 200 drug list, and you're going to see because there's 200 drugs and there's probably over 10 slides of them, you're going to see probably 200 questions on these drugs. So those questions are there. I also listed the answers for you to all of those questions for your review. Now, if that's not enough, I can post some more questions for you, but um, just let me know how I did and if there's anything else I could do to help you for preparing for the exam. Okay, and yeah, so and feel free to send me an email or you can feel free to comment. Um, Question if you find any video that um, you don't see it sound correct or see any mistake, just let me know so I can fix it and make it better for everyone else that's trying to watch it. Um, so the purpose of us pharmacists is so we can help people. So yeah, so I'll just leave this up for another 10 more minutes so you guys can leave any sort of feedback if you want, or even after the video. That is up to you. This video will be recorded, um, so you guys can take the time and um, study as well. But thank you for participating in my um, exam, in my review for this exam. So um, it will be up for another 5 more minutes for you guys, uh, just in case you want to, write anything down. And if you guys need any additional help, um, we do, um, we can do individual sessions as well. It's totally up to you. I wanted to see, uh, how you guys felt after watching this video. If you guys need any more further help, you guys need one-on-one instruction, I can do that for you as well. Um, you'll just have to let me know. All right, thank you everyone for um, taking the time to watch this video. I hope it has been helpful for all of you, and hope you guys are feeling a little bit better after watching this video, and um, is now able to get a little bit clearer understanding as to how to study for the exam. And so I hope you all have a great rest of the day. Again, I will post post the next sessions in the future, so you guys can um, come in when it's time. Um, so that's pretty much it. So, all right, thank you, everyone.